Chronic neurological diseases. Restless leg syndrome, Huntington's disease, amyotrophic lateral sclerosis and myasthenia gravis. Restless leg syndrome, RLS. Etiology relatively common, 5 to 15% of population. More common in older adults. More common in women than men, and women have earlier age of onset. Lower in Asian population. Types of restless legs syndrome. Primary, idiopathic. Majority of cases. Familial tendency. Secondary. Metabolic abnormalities associated fault with. Iron deficiency. Renal failure. Polyneuropathy associated with diabetes. Rheumatoid arthritis. Pregnancy, pathology. Primary RLS related to abnormal iron metabolism and functional alterations in dopaminergic neurotransmitter system. Exact cause unknown. Strong association between RLS and cardiovascular disease. Theories. An alteration in dopaminergic transmission in the basal ganglia. Axonal neuropathy. Brainstem disinhibition phenomenon resulting in motor and sensory disturbances. Clinical manifestations. Sensory symptoms. Motor abnormalities. Range from infrequent minor discomfort to severe pain. Unpleasant sensations, prickling, tingling, crawling, numbness. Pain usually in calf muscles, upper extremities or trunk can be affected. Discomfort occurs during rest, most common during evening or night. Discomfort relieved by activity such as walking or kicking. Compelling urge to move legs. Voluntary restlessness. Involuntary movements, usually during sleep. Clinical manifestations cones. Symptoms of RLS are aggravated by fatigue. Over time RLS advances to more frequent and severe episodes. Anemia, deficient iron conditions and certain medications, neuroleptics, lithium, antihistamines and antidepressants, can cause or worsen condition. Diagnostic studies patient history. Polysomnography studies to rule out other conditions, sleep apnea. To exclude secondary causes, CBC, serum ferritin levels and renal function tests. Patient with diabetes, evaluate diabetes management to rule out peripheral neuropathy. Management of RLS. Goal, reduce discomfort and distress and improve sleep quality. Treat secondary causes, DM, iron deficiency, renal failure. Encourage exercise, regular sleep pattern. Avoid activities causing symptoms, alcohol and caffeine, certain drugs, neuroleptics, lithium, antihistamines and antidepressants. RLS drug therapies. Dopaminergic agents, carbidopa/levodopa, pergolide, bromocriptine, pramipexole, ropinirole. Opioids. Benzodiazepines. Ropinirole, used to treat PD, for moderate to severe RLS. Anti-seizure drugs, gabapentin, Devilpro-X, lamotrigine, carbamazepine. Clonidine or propranolol. Nursing considerations. Sleep disrupted. Daytime fatigue. Disruption of daily routine, work performance, social and family life. Depression. Symptoms of RLS are aggravated by fatigue. Over time RLS advances to more frequent and severe episodes. Huntington's disease. George Huntington, MD, who first described the disease that bears his name. What is Huntington's disease? Huntington's disease is a progressive, degenerative brain disorder caused by a single defective gene on chromosome 4. This defect is autosomal dominant, meaning that an abnormal gene from one parent can cause disease, even though the matching gene from the other parent is normal. An affected parent has a 50% chance of having a child with Huntington's disease. Affects women and men of all races. Onset usually between 30 to 50 years of age. 30,000 Americans are symptomatic and 150,000 are at risk. No cure. Pathology of Huntington's involves basal ganglia and the extrapyramidal motor system. Deficiency of gamma-aminobutyric acid, GABA. Deficiency of acetylcholine, AC. Excess of dopamine. Clinical manifestations. Movement disorders. Abnormal and excessive involuntary movement, chorea. Writhing, twisting movements of face, limbs and body, getting worse as disease progresses. Facial movement involves speech, chewing and swallowing, can cause aspiration and malnutrition. Gait deteriorates and ambulation becomes impossible. Clinical manifestations count. Cognitive deterioration. Perception. Memory. Attention. Learning. Combination of motor and cognitive disorders results in complete loss of speech capacity. Psychiatric symptoms of HD. Depression. Irritability. Anxiety. Agitation. Impulsivity. Apathy. Social withdrawal. Obsessiveness. In stages of Huntington's. Weight loss in spite of caloric intake. Respiratory distress secondary to pneumonia. Fevers. Sleeping and deep lethargy during the day. Death usually occurs 10 to 20 years after the onset of symptoms. Diagnosis of Huntington's. Family history. Clinical symptoms. Genetic testing, DNA testing, fetal cells from amniocentesis or chorionic biopsy, can determine whether person is a carrier, but no tests available to predict when symptoms will develop. Treatment of Huntington's. Collaborative care is palliative. Medications to treat movement disorder. Tetrabenazine, specifically for HD, decreases amount of dopamine available at synapses in brain and decreases chorea. Neuroleptics, haloperidol, risperidone. Benzodiazepines, diazepam, clonazepam. Dopamine depleting agents, reserpine, tetrabenazine. Treatment count. Non-drug therapies for cognitive disorders counseling. Memory book. Medications to treat psychiatric disorders. Selective serotonin uptake inhibitors, sertraline, paroxetine. Antipsychotic medications, haloperidol, risperidone. Nursing management of HD. Provide most comfortable environment for patient and family. Maintain physical safety. Treat physical symptoms. Emotional and psychological support. Meet high caloric requirements, due to chorea. Discuss end-of-life issues with patient and caregiver. Home versus long-term care facility, artificial feeding methods, use of medications, advance directives, CPR and guardianship. Huntington's disease, a family tragedy. https://www.youtube.com/watch v equals Beekvo 9C9Q Forte. Where to find more info? More info available at Huntington's Disease Society of America. http://www.hsa.org/ Amyotrophic lateral sclerosis, ALS. What is amyotrophic lateral sclerosis, ALS? ALS is a rare, progressive neurologic disease, characterized by motor neuron loss for which there is currently no cure. Also called Lou Gehrig's disease. Usually leads to death within 2 to 6 years after diagnosis, some survive greater than 10 years. Usual onset, 40 to 70 years of age. More common in men than women 2 to 1. About 5,000 cases diagnosed in the US per year. Motor neurons in the brainstem and spinal cord gradually degenerate. Dead motor neurons cannot produce or transport signals to muscles. Electrical and chemical messages from brain do not reach muscles. Cause, unknown. Symptoms of ALS. Weakness of upper extremities. Weakness may begin in the legs. Dysarthria. Dysphagia. Muscle wasting and fasciculation, due to denervation of muscles and lack of stimulation and use. Other symptoms of ALS: pain, sleep disorders, spasticity, drooling. Emotional liability. Depression. Constipation. Esophageal reflux. Diagnosis of ALS: medical history, physical examination, EMG. Muscle biopsy, verifies lower motor neuron degeneration and denervation. Treatment of ALS: there is no cure for ALS. Death results usually from respiratory infection secondary to compromised respiratory function. Patient remains cognitively intact while wasting away. Medication to slow progression of ALS: riluzole. Riluzole decreases glutamate, excitatory neurotransmitter, in the brain. Moderate intensity, endurance type exercises for trunk and limbs, to reduce spasticity. Support patients' cognitive and emotional functions. Nursing interventions for ALS. Facilitate communication. Reduce risk of aspiration. Facilitate early identification of respiratory insufficiency. Decrease pain secondary to muscle weakness. Decrease risk of injury related to falls. Provide diversional activities. Help patient and family manage disease process, including grieving related to motor function and ultimately death. Research in ALS: mutation of the SOD1 gene causing ALS. Environmental factors, toxins, heavy metal exposure, warfare, pesticides. Therapies. Find more info at http://www.asa.org/research/about-ALS research/myasthenia gravis, MG. What is myasthenia gravis? Autoimmune disease of the neuromuscular junction. Characterized by fluctuating weakness of certain muscle groups. Occurs in either gender and any ethnicity. Prevalence rate, 6 per 100,000. Currently about 18,000 myasthenia gravis patients in the U.S. Can occur at any age, most common between age 10 to 65, infrequent over age 70. Peak age and onset in women in childbearing years. 2 times more common in women, but in older adults gender equally affected. Etiology and pathology. Autoimmune process, antibodies attack acetylcholine, AC, receptors. Decreased number of AC receptor, AC, sites at neuromuscular junction. AC molecules can't attach and stimulate muscle contraction. 85% to 90% of patients with generalized MG have anti-AC antibodies. In 10% to 15% patients' muscle weakness may relate to autoantibodies to muscle-specific receptor tyrosine kinase. 15% of patients have thymic tumors, most others have abnormal thymus tissue. Pathophysiology. Clinical manifestations. Fluctuating weakness of skeletal muscle. Strength restored after rest period. Muscles used for moving eyes and eyelids, chewing, swallowing, speaking and breathing are most often involved. Muscle weakness prominent by end of the day. In 90% eyelid or extraocular muscles are involved. Impaired facial mobility and expression. Speech is affected, fading speech. Muscles of trunk and limbs less often affected. Proximal muscles of neck, shoulder and hip more often affected. No sensory loss, reflexes are normal and muscle atrophy is rare. Peak sign of MG. The course of MG. Highly variable from short-term remissions, stabilization and severe, progressive involvement. Restricted ocular myasthenia, usually only in men, has good prognosis. Exacerbation of MG by emotional stress, pregnancy, menses, another illness, trauma, temperature extremes and hypokalemia. Drugs associated with worsening of MG, aminoglycoside antibiotics, beta-adrenergic blockers, procainamide, quinidine, phenytoin, psychotropic drugs and neuromuscular blocking agents. Major complications result from muscle weakness in areas that affect swallowing and breathing, aspiration, respiratory insufficiency and respiratory infection. Myasthenia crisis. An acute exacerbation of muscle weakness triggered by infection, surgery, emotional distress, drug overdose or inadequate drugs. Myasthenic versus cholinergic crisis. Myasthenic crisis. Cholinergic crisis. Causes. Exacerbation of myasthenia following precipitating factors or failure to take drugs as prescribed or drug dose too low. Overdose of anticholinesterase drugs resulting in increased ACE at receptor sites, remission, spontaneous or after thymectomy. Differential diagnosis. Improved strength after 4 anticholinesterase drugs. Increased weakness of skeletal muscles manifesting as ptosis, bulbar signs, difficulty swallowing or inarticulating words, or dyspnea. Weakness within 1 hour. After anticholinesterase ingestion, increased weakness of skeletal muscles, ptosis, bulbar signs and dyspnea, smooth muscle effects, pupillary miosis, salivation, diarrhea, nausea or vomiting, abdominal cramps, increased bronchial secretion, sweating or lacrimation. Myasthenic versus cholinergic crisis. Diagnosis, history and physical examination. Fatigability with prolonged upward gaze, 2 to 3 minutes. Muscle weakness. EMG. Tinsalon test. Acetylcholine receptor antibodies. Collaborative therapy. Drugs. Anticholinesterase agents, pyridostigmine. Corticosteroids. Immunosuppressive agents. Surgery. Thymectomy. Plasmapheresis. Second-line treatment. For immunoglobulin G. Nursing management of MG. Assessment, respiratory status, muscle strength, speech, swallowing, cough and gag reflex, coping. Nursing diagnoses. Ineffective breathing pattern. Ineffective airway clearance. Impaired verbal communication. Imbalanced nutrition, less than body requirements. Disturbed sensory perception, visual. Activity intolerance. Disturbed body image. Goals for patients with MG. Return of normal muscle endurance or maintain optimal muscle function. Manage fatigue. Be free from side effects of drugs. Avoid complications. Maintain quality of life appropriate to disease course. Nursing implementation. Maintain adequate ventilation. Continuing drug therapy. Observe for side effects of therapy. Appropriate diet. Diversional activities that require little physical effort. Teaching, medical regime, drug side effects, avoiding fatigue, community resources, complication of disease and therapy and management. Myasthenia gravis video. https://www.youtube.com/watch v = j80 remi swqs4. Reference. ALS Association. 2014. Our research. Retrieved. http://www.asa.org/research/about-ALS research/ Huntington's Disease Society of America. http://www.za.org/ Lewis, S., L., Dirksen, S., R., Heikemper, M., M., Bucher, L. and Camera, I. 2011. Medical Surgical Nursing Assessment and Management of Clinical Problems 8th ed. Street, Louis, Michigan, Elsevier Mosby. McCants, K., L., Huther, S., E., Brasher, V., L. and Rote, N. S. 2010. Pathophysiology. The Biologic Basis for Disease in Adults and Children, 6th ed. Maryland Heights, Michigan, Elsevier Mosby. Review questions. Which medication taken by a client with restless legs syndrome should the nurse discuss with the client? Select all. 1. Lithium, 2. Acetaminophen, 3. Ibuprofen, 4. Diphenhydramine. Answer 1. Lithium, 4. Diphenhydramine. Lithium and diphenhydramine, an antihistamine, can cause or worsen RLS. Question: secondary RLS is caused by metabolic abnormalities associated with what diseases? Select all that apply. Hyperthyroidism, renal failure, deficient iron condition, hypothyroidism. Answer 2. Renal failure. 3. Deficient iron condition. Secondary causes for RLS include metabolic abnormalities associated fault with iron deficiency, renal failure, polyneuropathy associated with diabetes, rheumatoid arthritis and pregnancy. Question: a parent with Huntington's disease has a % change of having a child with Huntington's disease? 10%, 25%, 50%, 75%. Answer: 3. A parent with Huntington's disease has a _50% change of having a child with Huntington's disease? Question: what are some of the movement disorders seen in Huntington's disease? Select all. 1. Abnormal and excessive involuntary movement, chorea. 2. Writhing, twisting movements of face, limbs and body. 3. Short, shuffling gait. 4. Inability to initiate movement. Answer 1. Abnormal and excessive involuntary movement, chorea. 2. Writhing, twisting movements of face, limbs and body. Short, shuffling gait and inability to initiate movement is associated with Parkinson's disease. Question: what are principal pathologic features of ALS? Select all that apply. 1. Excess of dopamine. 2. Motor neurons in the brainstem and spinal cord gradually degenerate. 3. Dead motor neurons cannot produce or transport signals to muscles. 4. Electrical and chemical messages from brain do not reach muscles. Answer: 2. Motor neurons in the brainstem and spinal cord gradually degenerate. 3. Dead motor neurons cannot produce or transport signals to muscles. 4. Electrical and chemical messages from brain do not reach muscles. In Huntington's disease is an excess of dopamine found, but not in ALS. Question: which of these manifestations would a nurse identify in a client with ALS? 1. Dysphagia. 2. Spasticity. 3. Paranoia. 4. Drooling. Answer 1. Dysphagia. 2. Spasticity. 4. Drooling. Paranoia is not associated with ALS. Question: what are principal pathologic features of myasthenia gravis? 1. Antibodies attack acetylcholine, AC, receptors. 2. Neurofibrillary tangles. 3. Decreased number of AC receptor, AC, sites at neuromuscular junction. 4. Deficiency of gamma-aminobutyric acid. Answer: 1. Autoimmune process. Antibodies attack acetylcholine, AC, receptors. 3. Decreased number of AC receptor, AC, sites at neuromuscular junction. AC molecules can't attach and stimulate muscle contraction. Neurofibrillary tangles are associated with Alzheimer's disease, and deficiency of gamma-aminobutyric acid is found in Huntington's disease. Question: what are some nursing diagnoses for myasthenia gravis? Select all that apply. Ineffective breathing pattern, activity intolerance, impaired verbal communication, impaired memory,